So Dr. Baig is going to share with us things that we all should know about heartburn and reflux. Heartburn or acid reflux is almost like a common cold in every household, with so many people suffering. It has become widespread and potentially serious. Doctor, can you please tell us about its causes and symptoms?
Yeah. So it's true, Shraddha, that this is a very common disease. I'm so happy you said it's as common as the common cold. That's true because three-fourths of the world's population has experienced in the past or is experiencing heartburn or reflux. So it's a very common problem. However, when we talk about gastroesophageal reflux disease, which is GERD, it has a specific definition, which means the heartburn and reflux should be of a particular intensity and duration throughout the day. And then only we can call it a disease, right? So just because I had a heartburn in the morning doesn't categorize me as having a reflux disease or a gastroesophageal reflux disease or GERD as it is commonly called. What are the causes? Well, one could have a GERD right from childbirth if one has an anatomical defect. And before I proceed further, let me explain for the audience what GERD means or GERD means. We have an esophagus right here in the chest through which we swallow our food from the mouth to the stomach, right? And then from the esophagus, the food travels to the stomach through a sphincter at the lower end of the esophagus. Now that sphincter is univalvular, it is unidirectional. It will allow food to go from the esophagus to the stomach, but ideally, it should not allow any acid and food to come back into the esophagus, right? That's how when we have our food, it doesn't come back into our mouth. But in certain people, for reasons, anatomical reasons, this sphincter may be damaged. There may be a condition called hiatus hernia, or there may be certain conditions in the abdomen, like obesity, like pregnancy, right? Pretty common things, right? Obesity and pregnancy. And this can cause increase in the pressure in the abdomen and push the acid and the food back into the chest. So from birth itself, hiatus hernia, a congenital problem, pregnancy, obesity, all these can produce a reflux disease or GERD. These are your common causes. And there are some contributing causes. We'll come to that. I think you also asked me about the symptoms. Am I right?
Absolutely.
So heartburn and reflux. Heartburn is something that everybody knows. Seene mein jalan ho rahi hai. I'm feeling a burning sensation in my chest. That's what everybody complains when you're having spicy food or something like that. There's another symptom which is common, and that is reflux. Whatever I ate, it's trying to come up in my throat. I can feel a squeeziness in my throat, in my chest. But there are certain symptoms which people are not aware of. And this is very important. Some people will land up with an ENT physician. Some people will land up with a cardiologist. Why? Because this reflux also causes change in the voice, can also cause change, asthmatic reaction, can also cause chronic cough. So one would think, oh, there's some throat irritation, let me go and show an ENT. But what basically is happening is here, the acid vapor is irritating the throat. So we must be aware that if you have a chronic cough, chronic breathlessness, or a change in the voice, you could be having GERD, a very simple problem. Also, some people can experience chest pain and breathlessness, and they may land up with a cardiologist. And unfortunately, some patients even undergo a stenting because of a wrong diagnosis. So a GERD can also cause chest pain because the acid is coming up, the esophagus tries to contract, and there's a squeezing pain. One feels it is a heart attack. So these are some common and uncommon symptoms of GERD or gastroesophageal reflux disease.
Okay, that's quite interesting. And I mean, though some of the causes seem very obvious, but the symptoms are often overlooked, I think. And sometimes the way the human mind works, as you said, we imagine the worst. So, thinking of having a chest pain, you always think of the worst, that it's a heart issue. So, doctor, like you said that, one symptom could be, GERD instead of a heart pain. But how can one tell whether it's GERD or a heart problem? Because, it is like something alarming.
Yes, absolutely. Very important. So if one is an elderly, obese, has had a heart attack, having a chest pain, think of a heart attack. right? If you look at the sky, you don't expect to find elephants. You expect to find crows. So expect a crow. And if you're a young person, poor lifestyle, late sleeper, stress, alcohol, smoking, everything doing rounds, and you've had a spicy food in the evening and you've just woken up with a chest pain, think of GERD. It may not be a heart attack. Okay. So it is all about the context. It's all about perspective. However, I'm sure there are some discerning individuals who will say, this is not enough. I may be mistaken. What is a test that we can do? Of course, we can do a test. One may do an ECG and a Trop-T test from a cardiac point of view. They may be a little equivocal in some patients. We can also do something called endoscopy, esophageal manometry, pH metry. Now, these endoscopy, most people understand. Manometry and pH metry are not available everywhere. For example, our center is the only center for foregut clinic in Eastern India. So we know about these particular tests. If we do these tests, we would know if somebody is having a reflux or not, somebody is having a heartburn or not, and it is because of the acid reflux. So these are some specific tests for GERD, and there's some specific tests for cardiac problems. So that is how you can differentiate.
So doctor, are any of these tests invasive?
So endoscopy is invasive. Something has to go down your mouth. I would mention here, many of us, including myself, if I had to undergo an endoscopy, and I've had in the past, I would take an anesthesia because I'm not comfortable somebody putting a tube in my mouth. The unfortunate part is in the city, many of the busy gastroenterologists think, let's do it without anesthesia. But if you are not comfortable, do it under general anesthesia, but don't escape endoscopy. It's important to do an endoscopy to diagnose GERD. Also, the manometry and pH metry are done by putting in electrodes during the endoscopy. So even that is invasive. So yes, unfortunately, these are invasive tests, but not necessarily uncomfortable, if that's what you are asking.
Sure, get it. So now what are the common triggers for a heartburn?
Now, here is the thing. Some diseases are lifestyle diseases. You would know one, obesity, right? Obesity is a lifestyle disease. It's a disease, but it's probably because of the food habits, the sedentary lifestyle, lack of exercise, and so many things which we may not mention here. Similarly, GERD or a gastroesophageal reflux is a lifestyle disease. And it happens because of poor stuff like stress, like late sleeping, watching TV and sleeping, like eating a heavy dinner and going to sleep immediately thereafter. No gap in between. Remember, our grandparents used to tell us, don't sleep immediately after having food. At least have a 2 hours gap, right? And there are irregular habits as well, spicy food, but tea, coffee, smoking, and alcohol. And I keep that as last items on my list because I know each one of us consume tea, coffee, and alcohol and smoking, and these are so much a part of our lives, but it doesn't need to be. I always like to throw a philosophical question. How do you know this is normal? Is the COVID, which is like a pandemic now, is it the normal? No, it's not the normal. Just like COVID is not normal, having alcohol is not cool. Doing smoking is not cool. It's not. And therefore, if you stay away from these two things, chances are your GERD is going to be much, much better. Those are the changes you need to make in your lives.
Sure. So talking about that, the best possible solution for a heartburn, doctor, which one would you recommend? A lifestyle change, medication, or surgery?
First, lifestyle change. If you don't want to change, don't expect your doctor to change anything for you. So first is yes, lifestyle change, because we do bariatric surgery as well, deal with obese people. Same thing with obese patients. If you're not able to change your mindset, it's very difficult for any medication or surgery to work for you lifelong. It may work for you for a few years, but not lifelong. So in GERD, in gastroesophageal reflux, heartburn, and reflux diseases, it's important that one changes a few things. For example, if you're very stressed out, do some meditation. If you are into a lot of alcohol on a daily basis, cut that down. If you're a smoker, cut that down or practically give it up. If you're having late nights, try to improve your sleep cycle. Don't have a heavy meal and just go to sleep thereafter. Keep a gap. There are so many things which are doable. These are correctable, right? These are under your control. And when it comes to making those changes, and then you also want medications, of course. So there are two kinds of medications. One are antacids. So if I take a syrup of Digene, Gaviscon, Mucain gel, all these are going to help me, right? They're going to help me because they're neutralizing the acid which is refluxing. Here, one thing we must remember, not only we have acid reflux, we have alkaline reflux as well. And these are also dangerous. But I'll not go deeper than that. But just let you know that not all the time antacid is going to help, because the alkaline reflux is not going to be neutralized with the alkaline syrup that you're consuming.
Sure.
A. B, there are some things called acid suppressing agents. We could reduce the acid in the stomach by giving ranitidine, cimetidine, omeprazole, pantoprazole. These are drugs that most people now know because it is available over the counter. And people just go and take it on demand. Okay, I took it for 1 day or 2 days and then I left it like that. Although that's not permissible, but that's still acceptable. And many of these patients do very well. And now I know a lot of my patients who take these drugs regularly for years, and maybe decades. And earlier, and when these molecules were launched, they were thought to be very, side effect friendly. They did not have too much of side effects. But now we know that these medications also have side effects. For example, recently we came to know that pantoprazole can lead to kidney damages. So if you're consuming these drugs on an indefinite period, you can have kidney damage. One can have bone disease. The bones can become weaker. And you can also have pneumonias. Now, these are things that we were not aware of earlier. So all these drugs, which are consumed over a long period of time, can have side effects. Unfortunately, a patient always believes a drug is safer than surgery, which is true in some respect, but not entirely. Not entirely. We have to understand a drug has side effects. And over a period of time, it does lead to a lot of side effects. So now I've covered lifestyle, I've covered medications which are available, with the caveat that you cannot consume drugs indefinitely. Now those are the recent evidences coming up. So now that brings us to intervention. Intervention could be endoscopic or surgery. Endoscopic is just on the horizon. It's on the experimental level and just entering into clinical practice. But surgery is being around, and it's a very effective thing. If you want, I can continue with telling you about the surgery, or I can take the question and then come back to surgery. What do you want, Shraddha?
Please tell us. We would love to know about
Okay.
this.
So, when do we say, okay, no medication for this gentleman or this lady, we need to go for surgery? First, let me build a perspective. In the United States, for GERD, 95% patients are managed on medicines, 5% are offered surgery, 5% patients undergo surgery. In India, 99.99% patients have medications and 0.01% undergo surgery. And the reason is there is a lack of awareness. There's a lack of patients' trust on surgery. There's a fear for surgery. So patients generally like to push themselves. But it's not only true for GERD. I think for other diseases as well. If you can manage with a medication, you don't like to get a heart surgery. If you can manage with medication, you don't want to have a stone surgery. But there are times when you say, no, you cannot just continue with medication. It's not going to help you, or it's going to be dangerous, or it's not going to work for time. So what are the indications for surgery in a simple language? A, if somebody's been evaluated for GERD, for reflux and heartburn, and they find a huge hiatus hernia, then that hiatus hernia is not going to get benefited. Not all of these hiatus hernia are going to get benefited with medicines. They will need a surgery to fix them. So that's number one. Number two, somebody is hugely obese. BMI is more than 40. Somebody like 120 kgs, 140 kgs. It's not going to work. Medications are not going to work that well. You need to reduce the abdominal pressure by bringing the weight down, either through diet activity or through bariatric surgery. But one needs to bring that down, and that is going to cure the reflux. Then there are patients who've been consuming drugs for ages, and now they show that they are not helped because the reflux is not going. The heartburn is going away, but the reflux is not going. It makes them wake up in the night with reflux, and they squeeze the chest. Some people have a change in their voice, and they're singers. They don't want that. Some people have a tightness in their chest like a cardiac pain. They want to have relief. So these patients will be benefited with surgery rather than medication. Lastly, if somebody is continuing with medication for years and you have developed a kidney problem or a bone density is getting decreased or you get recurrent pneumonia, it's time to consider that these drugs are going to have side effects. Let's get to the next level, get a surgery done. Now, having said all of this, that would amount to 5% of patients going from medication and lifestyle to surgery. And surgery, the fear of the surgery has to go away. It's a simple laparoscopic surgery. You have 3 or 4 holes. A patient comes in the morning, gets a surgery which takes about 30 minutes to an hour, and next morning they are home. They consume about liquids for about 3-4 days, and they're back on their diet. There is hardly any change in their activity. They can return to work in about 4 or 5 days time. So it's not a very cumbersome surgery, or neither does it take too much from the patient. But the problem is that the patients are not aware of their options. Patients are not counseled about their options, and therefore they keep on persisting with medications. Having said all of this, I must say, go back to the first statement I made. Nothing will work unless you change your own lifestyle, though. Okay.
That's so true. And we just come for a quick remedy and we don't really understand. And as you said, counseling is very important. That I think that's one of the most important things, to understand the issue. So talking about the surgery, what are the advancements in the treatments or procedures for acid reflux?
Yeah. Now, let me build the base here first. We must not forget the basic. What is the problem if we do not treat the reflux and heartburn? Well, the quality of life is going to be very poor. Imagine waking up every morning with a heartburn and you want to have a bottle of antacid every day in the morning. Quality of life. 2, very important, cancer. Esophageal cancer is a direct relation to GERD or heartburn and reflux patients. In the West, it's the commonest, it's one of the commonest cancers because there's so many people with reflux. And out there, the obesity levels are higher, so they have more reflux. But in India now, obesity levels are not low anymore. So it's 4% obesity rate. And that is amounting to a lot of patients having reflux, considering the vast population in the country. So quality of life is the reason why one should treat 2, esophageal cancer. One must be aware why we are doing it. So what are the advancements now? We are not aware, at least patients are not getting aware they need to get it treated. It's a serious disease. It's not a disease which say, okay, just a heartburn, nothing big, nothing important. No. You need to get evaluated. So awareness has improved, 1. 2, the testing tools have improved. The symptomatic questionnaires have improved. So if I had to question somebody, I'll send a list of 20 questions. Please tick mark. And I will know what grade of the severity of symptoms I am looking at. If I'm looking at a mild GERD, moderate GERD, severe GERD, I would know how to deal with the patient. That's 1. 2, there are tests available like pH metry, esophageal manometry, endoscopy, even some barium series, which can pick up very effectively, especially the manometry, very effectively, what is the precise problem. I don't like to confuse people, but this is a huge science now. The more we are doing manometry, the more we are realizing not all chest pain, not all heartburns are because of GERD, gastroesophageal reflux. Some of them are because of some other disease like achalasia cardia. There's something called jackhammer esophagus. All that, a doctor, I wasn't aware of it about 25 years back when I passed out from my post-graduation. But now we have become more and more aware. We know about this science much more. The manometry has changed the way we can understand patients' motility. Third, we now know whom to put for medical management and whom to put for surgical management. And that can be done laparoscopically, no cutting open, just holes, and you can do that. So that's a huge advancement. 30-minute surgery, imagine, that's amazing. Then there are endoscopic treatment. As I said, it's on the experimental level coming into the clinical horizon. And there is something called a magnetic sphincter augmentation. Nowadays, at the lower end of the esophagus, where I told you things can get weaker and the patient can have reflux from stomach to esophagus rather than from esophagus to stomach, the valve is gone. We can now go in laparoscopically, and instead of doing anything out there, we can just apply a magnet around it, a magnetic ring, and that can squeeze the esophagus at the lower end. And this is a beautiful way of moving forward. We are becoming even more minimally invasive. We are becoming even more physiological, more functional, if you may. we are not disturbing what God has given us. So what nature has provided, we're not disturbing them, just adding this. So these are things which are coming up. Most important, before I sign off, surveillance. Now we are aware it can lead to esophageal cancer. So now we put the patients on a regular endoscopy if they have GERD, and we pick up stages before they turn into cancer, called Barrett's esophagus. And we know precisely how to treat them. We can do ablation with radio frequency probes so that these lesions do not progress into cancer. So we are now also preventing cancers. So this entire thing is a lot of advancement in this particular area.
That's a whole lot of information. Thank you, doctor, for giving us insight, because we never think of like having a common thing like a heartburn or reflux and treating it with medication, and which goes into like diseases like cancer. So coming back to bariatric surgery, doctor, I know you are doing that, and you are the different thoughts that people had regarding bariatric surgery, whether it is advisable or not. I want to come to another angle. So can weight loss as a result of bariatric surgery help in relieving acid reflux?
Okay. So there were two questions out there. One, what is the status and acceptance of bariatric surgery? And two, how does it help in reflux patients? First thing, bariatric surgery is been around since the 1950s, but it was done as an open surgery, and mostly in the States because obesity was their problem. In India, obesity is a recent problem. In the last 3-4 decades, now you see school children. If I just stand outside the school, I see about 40% of children are now already obese, right? Don't like to call them obese, but yeah, they are. They have more weight. And even in the adult population in the society, you see in the urban metros, it is increasing. So obesity is increasing. And how do you treat obesity? Well, you could do diet and activity. There are hardly any effective drugs so far. And then you can do surgery. Now, diet activity is definitely the first go-to. As I said, if you don't change your lifestyle, don't do anything else. So no doubt about that. But with patients who are like 140 kilos, 150 kilos, 180 kilos, 200 kilos, I always ask my the critiques of bariatric surgery, tell me another option. Don't give advice that this is not a great surgery. Just give an option, give an alternative. The fact of the matter is, in scientific world, we now know that for morbid obesity, there is no other option as effective as bariatric surgery. Even with its even with its disadvantages of nutrition and the fact that you have to be on a lifelong supplementation and monitoring, it is still the best option for people with morbid obesity, who have uncontrolled diabetes, who have sleep apnea, who are struggling to sleep in the night, who have refluxes, who are not able to get pregnant, who are not able to go into the society with and get married. There's so many people who are depressed in the house because they don't want to come out with that shape. So when we criticize bariatric surgery, we forget to give an alternative, and two, we do not realize what we are denying. It's like denying religion to people who are emotionally and spiritually starved. So that's the first part of the question. The second part is, when we see an obese patient who is a refluxer, there are two options. We can put the patient on medical management if there are things like hiatus hernia, as I said earlier, and the patient is not responding to medical therapy. There's a lot of reflux. The patient is developing pre-malignant, pre-cancer changes. So we need to shift our focus. We need to go for surgery. Now, what surgery will we choose? Should we choose the surgery for heartburn and reflux, which is called laparoscopic fundoplication, or should we go for bariatric surgery, which is the Roux-en-Y gastric bypass? So let's just call them fundoplication or a gastric bypass. So bariatric surgery or anti-reflux surgery. Now, if the patient is not morbidly obese, both choices are good. If the patient is morbidly obese, then just doing an anti-reflux surgery may not be as effective as a bariatric surgery, because the body weight is not low, and these patients will tend to come back with a recurrence of the problem. There will be a failure of the problem of the surgery in significant percentage. Therefore, for morbidly obese, which means somewhere about 120 kgs and above patients having reflux and heartburn, those patients are going to benefit more with bariatric surgery. They will reduce weight. They will have immediate effect on their reflux. So a gastric bypass is 100% effective for an obese refluxer. It's that good. Whereas a fundoplication is like 95% effective for patients who are going to be obese refluxes. So we need to understand that these two subsets where we will use which kind of surgery. So there is definite role for bariatric surgery in an obese refluxer. Just one caveat. A lot of patients think of bariatric surgery as one procedure, gastric bypass. It's not true. There's another procedure called sleeve gastrectomy. And then there's some minor modifications. Let's not go into that. Sleeve gastrectomy and gastric bypass. A sleeve gastrectomy is contraindicated for refluxes. For patients obese refluxes, they should not undergo a sleeve gastrectomy. They will reduce weight, but the reflux may get worse. That's just a caveat out there.
Okay, that's a whole lot of information to digest. It's like,
I wish I could have been briefer and simpler.
No, it is not such a simple topic, so I'm thankful that you explained it so well. So I understand that, the patient before really coming to the doctor or even after visiting the doctor has to do a lot of things as, lifestyle changes. So how can diet be used to totally reverse acid reflux totally by first doing a lifestyle and a diet change? So can you give us some suggestions and examples?
Shraddha, I lost the voice signals sometime. Can you just, you are asking about the diet. Yeah, please.
Yes. How can diet be, changed to totally reverse? And can we reverse acid reflux by changing our diet?
Yeah, I think that's a very good question. I've already touched a little bit. I'll reiterate what I said earlier. You see, this is a lifestyle problem. Part of it is because of the stress, the sleep cycle, and obviously the addictions like tea, coffee, smoking alcohol. And there's the fourth component, which is the diet. So if we touch this component, the diet component, yes, it will help us. It will definitely help us. What are the things that we can do in our dietary as a part of dietary modification which will reduce the acid reflux? A, do consume less spicy food. That's number one. Hot and spicy food tends to deteriorate produce more acid in the stomach, and then they tend to come up, and then one has heartburn. Two, as soon as one has a heavy meal, you tend to have more reflux. So please do not take heavy meals. You can distribute your meals from 3 times in a day to 6 times in a day, right? So you have small bits distributed to 6 times in a day. So that's number 2. Number 3, have your food and just don't lie down. That typically happens in the night. So have your food, spend about a couple of hours, then go to lie down in your bed. So that's the third very important point. Number 4, well, tea and coffee are also part of the diet. And once you see there's a heartburn and reflux, don't take so much of tea and coffee to make it worse. I know some people like to take cold milk, which is fine, except for a few percentage of people who can get worse with cold milk because they have a problem with milk. Milk can also improve or augment calcium secretion from the stomach in some patients and cause more production of hydrochloric acid. So there is a little bit of a twist out there. But generally, cold milk does help people. Lastly, many of us think we can have a cola when we have a heartburn, and that is going to down all the fire which is there in my chest and in my stomach. Sorry, it doesn't happen. It makes it worse. So that's the commonest misconception that I find. And I also find one more misconception is some people consume a lot of Eno and Pudin Hara. I'm sorry, I have to name certain things here. But no, you cannot just rely on those things. As I have said in the last 35, 40 minutes or so, you need to understand there's acid reflux, there's alkaline reflux, and we need to know what is your severity of reflux. We need to know whether that is actually the cause of your problem. And then there are antacids, and then there are PPI, proton pump inhibitors like omeprazoles and ranitidine, and everything has got a place. So you just cannot self-medicate yourself with these things over a long period of time. Yes, on and off you have this and you did it, it's fine. But if it's happening on a regular basis, it is not a good idea to self-medicate with these products which are available in the market.
Right. So that gives the audience a lot of take home for do's and don'ts regarding heartburn and reflux. So I think that's quite comprehensive.